So, a very good evening to all of you who have joined here. And on behalf of the ICOG chairperson, Dr. Parag Beniwale, I have this honor of inviting all of you into this webinar, which is a unique webinar and has been named as the ICOG Tarun Abhiyan. This was Sir's idea of encouraging the youth of Foxy and ICOG to come forward and present scientific topics and deliberations in a very professional manner and grow up as good speakers for the future generation. And we are very lucky to have some of the dynamic Foxians like Professor Naren Malhotra and Dr. Suchitra Pandit, who have agreed to be mentors. So we all know how busy and how stressed they are with their times, but they have taken out time to come here and sit through the presentations, which will be done by completely youngsters. These are the alumni of the ICOG who have done certification courses with the ICOG and are still in the early stages of their career. So we are looking forward to a very unique webinar, and I would request Dr. Parag to say a few words and get this started.
Yeah. Thank you, Chinmay. Okay, the president is here, so let's request the president to address the gatherings.
Absolutely.
Just to give you a brief, we are just about to begin the Foxy ICOG Tarun Abhiyan. Now, this is a result of the discussion that took place in the managing committee at Gurgaon, where a youth cell led by Dr. Narendra Malhotra and Dr. Suchitra Pandit gave some suggestions, and we in ICOG volunteered that we will have this particular program, and here we are with the first episode, and we cannot wait to hear from you because it is our baby, and we want you to encourage the youngsters who are here.
Thank you so much. Is this the Foxy Zoom platform we are taken?
This is the ICOG one which we are using.
Okay. Because we have to have I made a rule for a Foxy platform that no admission. So एक बंदा काम ही करता बैठता है. Many people are in a waiting room. So everyone, once they join, I just changed that to make it more user friendly. Nevertheless, first of all, I'm so thankful to the entire cell committee. And when you have a Narendra and Suchitra on the top of that, I mean, not saying they are like-minded people joined to both of them, and this is really the youth cell. I think this is the advantage. One day we all work there, we have spent so much of time, money, energy, and if we don't do anything with that, is so then the best of all. So I'm first congratulate this cell for doing amazing work under the leadership of Narendra Suchitra and Chinmay Parag. Thank you so much. Parag, taking it under the wing of RCUG was a fantastic idea. And then Chinmay reported me that this whole this all has been planned and getting executed by the youngsters. And the seniors and leaders are just guiding them, mentoring them. I think, Parag, you must remember in our POGS also, we have always the mentor-mentee sessions, and we always love. I think this is the important thing. If Foxy ICOG comes together and ensure that our next generation, they are brought into the flow, and we show them the organizational skills, the leadership qualities. We bring out their creativity, their passion, how to perform. Our Foxy will be always rich and the best and most strengthful organization globally. Today, I see the FIGO, the way FIGO respects Foxy. Means, just for an example, I wanted 90 minutes side section into the FIGO for my Sampurna project. And I received not only immediately yes as a reply, but the Zoom meetings with the CEO, and everything has been planned. If the Foxy is respected so much, is only because of our, the work what Foxy does years and years. And if we have to have a sustainable model, I started using the word advocacies and sustainable and all, which in a clinical practice you don't use those words. But then what we need is this youth. So I'm thankful to these two youngsters and thankful to our youngest ICOG chairperson. Always young, always youth. We always tell him he never age is the same since I'm watching him and I am with him for last 3 decades. So thank you so much. Thank you. Thank you for taking this project. And I think this is here to sustain years after years because this is one of the most needed and the wonderful program. Narendra Malhotra and Suchitra were age otherwise also in their thinking and in their actions. They never age. So we have a right people at right place. Thank you.
Thank you, Sunita. In fact, when this project was thought about, I was in particular happy because it was the year 2008 when I became the chairman of the Young Talent Promotion Committee. I had taken over the committee from Suchitra. And in the year 2008, Dr. Narendra Malhotra was the president and Dr. Suchitra Pandit was the vice president in
Vice
charge of the
President.
committee. So my journey in the committee as a committee chairperson has begun with these two people. And I again have an opportunity to work with them.
with them.
Thanks to you, that this Foxy ICOG Tarun Abhiyan is taking place. And I must appreciate the tremendous work put in by Chinmay. Uh, so Chinmay was the first one who I contacted when we decided to plan this particular activity. And one good idea that she came up with was we should get in touch with last 5 years candidates who did certificate course with ICOG. So she immediately created a Google form. We circulated it to all, and then we picked up four brilliant people out of it. So excellent.
Fantastic.
And Sunita, I'm very happy to say that next month probably we'll come up with the similar Taruna Abhiyan for endoscopy, and I would certainly seek your presence, and we'll of course decide a date as per your
Always.
convenience.
Always. Always.
Yeah.
Thank you so much. Thank you.
And I'm looking forward to some interesting session today because we have youngsters, Asit Kumar Jena and Dr. Brinda Barcha, who will be making presentations. Of course, they will be guided by Dr. Narendra Malhotra and Dr. Suchitra Pandit. And there would be a debate by Dr. Bhumika and Dr. Kanan, where we have Dr. Uday Thanawala, the past chairperson of ICOG, and Dr. Sadhana Gupta as the judges. So
Fantastic, yeah. It will be a fun. Fantastic.
Yeah. So I'm looking forward to
Believe me,
interesting.
when I was a MSR, just 1 minute, I was a MSR, one program, we had 2 days conference, 6 oration. I gave to only youngsters the oration. Believe me, they were better than anyone. They were not watching the slides. They were watching the audience and using the slide sorter. They were knowing what is going on behind. So much prepared with the slide numbers, the oratory skill. So I realized that was one of my most memorable conference. It happened in 2018, but I still have a memory so fresh. So I think these youngsters, they are better, they are well read, and they know how to debate.
Parag,
Yeah.
may I just say
Yes,
something?
of course.
Sunita, thank you very much for those lovely words. But I wanted to just bring back one very wonderful memory. 2002, when I took up the Young Talent Chairperson. 2004, we had a Spot the Young Talent competition, and we had come to Pune. And I remember you were a budding endoscopic surgeon at that time, and you presented your uterine manipulator and how useful it is for, it was an innovation And I remember you got the first prize at that time. And I
Okay.
still have
I
that
need to have this in my biodata now.
and I still have that manipulator. And that time I said, Parag, he कोण आहे रे नवीन? तेव्हा पराग told me की नाही आता ही ना endoscopic surgery करते सोलापूरहून आलेली आहे. So it was, I feel very good that, we are all linked and we all respect the fact that the younger people have to be promoted. Sunita, your words have been very encouraging for everybody. And thank you for always being like that. Thank you.
Thank you. Thank you.
Thank you. Chinmay, let's begin with the
Yes.
program.
Thank you so much, Sunita ma'am, for the vision of doing this, and Parag sir for putting all this together. So we have with us the mentors for the young generation, and they have been past presidents of Foxy. They are exemplary people, and really it's beyond me to introduce them to this gathering. But what's more important is we always get inspired whenever we see their CVs and whenever we see them present things on stage. Today, I have the honor of requesting Professor Narendra Malhotra and Dr. Suchitra Pandit to take on this session as mentors. So, sir and ma'am, we have two youngsters in fetal medicine, Dr. Asit Kumar Jaina. He's currently practicing in Bhubaneswar, and he has completed his ICOG certification course in fetal medicine and is presently in the SUM hospital in Bhubaneswar and works in obstetrics and fetal medicine. And he has prepared a talk on fetal aneuploidy screening in the first trimester. We also have with us Dr. Brinda Barcha, and she is practicing in Jamnagar, and she has also completed her ICOG certification course in fetal medicine from Ahmedabad, and she will be talking on how do we confirm the diagnosis of IUGR. So both of them will present their talks, and then it's up to you how you want to, whether you want to ask them questions at the end of the talk or just give a comment on how they prepared, how they can improve on their preparations, and what should be their future approach to presentations. So the session is all yours to the mentors, Professor Malhotra and Professor Pandit.
Chinmay, can I just say something? Because I have an
Yes.
emergency, I have to go and come back. But
Yes.
congratulations to you for getting this whole thing put together. And of course, thanks to our president, Dr. Sunita, and our chairman, Dr. Parag. And, I remember recently in Gurgaon when we had this program, Dr. Narendra Malhotra, myself, and all our wonderful team, including Niharika, yourself, and Parag, all of us had got so many ideas. I've sent all of them to the president, and the secretary general, and I'm very happy that you have taken this as a first activity. So brilliant, and I'm very eager to listen to both the speakers. And you'll have to just excuse me for 15-20 minutes. I'll just have to go and see that emergency and come back. And meanwhile, Dr. Malhotra can take on. Yeah. Thank you so much.
Thank you.
Very good evening to all of you. Welcome, youngsters. So let's, without wasting any time, let's go to the first presentation of first trimester screening, I think. So Asit,
Yes,
I
yes.
think you're going to talk on it. And we'll just make a few comments. And if there are some doubts, we'll try to clarify. All those who have joined live, please put your questions in the chat box so I can just ask them or try to answer ourselves. So, welcome, Dr. Asit. All yours. Stage is all yours.
Thank you so much, sir. A very good afternoon, everyone, all the respected teachers, seniors, colleagues, and juniors. At the very outset, I would like to thank Sunita ma'am, Naren sir, Suchitra ma'am, Parag sir, Chinmay ma'am, and all the mentors for giving us this wonderful opportunity. So our topic of discussion is first trimester screening for aneuploidies. So this topic revolves around three concepts: first trimester, aneuploidy, and screening. From our school days, we know that human body is made up of cells that contain a nucleus. In the nucleus, there are 23 pairs of chromosomes, one from each parent. These chromosomes are made up of genes, and if you open up the genes, they contain the DNA. So at the DNA level, if it is affected, they're called single gene disorders, and disorders affecting at the level of chromosomes are chromosomal abnormalities. These chromosomal abnormalities may be abnormality of number or abnormality of structure. Abnormality of structure may be translocations, deletions, but what we are concerned is the abnormality of number. If there is an extra chromosome in each of the 23 pairs, we call it polyploidy. But if there is an extra chromosome or a missing chromosome in any one of the chromosome pairs, these are called aneuploidies. So aneuploidy is the presence of abnormal number of chromosomes in a cell. Why are you worried about? Is that the overall incidence is about 1 in 150 live births, among which Down syndrome or trisomy 21 accounts for 1 in 700 live births, trisomy 18, 1 in 3000, trisomy 13, 1 in 6000 live births. Klinefelter syndrome, most common sex chromosomal aneuploidy, affects 1 in 500 males, and Turner syndrome affects 1 in 2500 live births. So why are we concerned about the first trimester? From time immemorial, we know a pregnant patient comes to a doctor for a checkup. Every 4 weekly she is called till the 28 weeks. Then after that, twice weekly till 36 weeks. And then every weekly till she delivers. And this is the traditional model of antenatal care. But with the advent of modern technology, screening methods, and maternal fetal medicine, the tables have turned. So the 12 weekly fetal evaluation is now of utmost importance, where we actually classify the women into low risk and high risk category, so that the high risk women are actually followed up properly. So the earlier we screen, the better. Now, what to screen, why to screen, whom and how to screen. The concept of screening is it is a test which is applied to apparently normal population, which in our case is all pregnant women. So all pregnant women should be offered a screening test. The result comes as a high risk or a low risk according to the cutoff values. So those who are above the cutoff values are identified as high risk for a condition, which we pick up those high risk for a condition and we apply a diagnostic test to them so that we can identify the abnormal or affected conditions. So the result is either high risk or low risk, but we must always remember the screening is not a diagnosis. So they do not confirm or rule out the condition completely. So any decision for termination of pregnancy should not be taken based on these screening results. So what are the methods to screen? First comes the history-based screening. Every pregnant woman carries an inherent risk of having a fetus with a chromosomal abnormality. This is called a background or a priori risk. It includes maternal age, race, history of smoking, mode of conception, whether she has conceived by IVF or spontaneous, or history of previous pregnancy with aneuploidy. We all know risk for aneuploidies increases with maternal age, except for Turner syndrome and diploidies. After age 35, the risk increases exponentially. Similarly, among the black race, the PAPA levels are increased, while those who have a history of smoking and those who have conceived by IVF, the PAPA levels are low. So actually, when the screening methodology came up, if we go into the history of fetal medicine, they actually took out those above 35 years and they put a needle into the uterus. The problem was many of them came out to be negative. So we thought of some methods so that we do not invade the GSAC, but we have something to help us in screening. So we took the help of the placenta, rather the hormonal function of the placenta. And among all these hormones, we could identify that the beta subunit of the human chorionic gonadotropin and the pregnancy associated plasma protein A levels somehow correlate with aneuploidies. We saw that there is in trisomy 21 fetuses, there is a twofold rise in the beta HCG levels, or which is more than 2.5 the multiple of median. While the PAPA levels are low, it is less than 0.4 multiple of median. While in trisomy 13 and 18, both the beta HCG and PAPA levels are low. So then came the concept of double marker screen when we included the free beta HCG and PAPA levels. But this gave us a detection rate of almost 75 to 80%. So magnificent discovery came in the 1990s when Professor Kipros and group, they saw that the sonographic appearance of collection of fluid under the skin behind the fetal neck in the first trimester of pregnancy, which we call the nuchal translucency, is a very good indicator to screen for aneuploidies. The incidence of chromosomal abnormalities related to the size rather than the appearance of NT. We all know NT is a measure of CRL or the crown rump length. So it is measured when the CRL is between 45 to 84 mm. In euploid fetuses, the NT increases with CRL. In trisomy 21, NT is more than 95th centile in 75 to 80% of fetuses, irrespective of maternal age. And the 99th centile is about 3.5 mm and it doesn't change with CRL. So the larger the NT, higher the risk. What are the implications of high NT? Increased fetal nuchal translucency thickness is associated with trisomy 21 and other aneuploidies, more than 50 fetal defects and genetic syndromes, congenital heart defects. However, in majority of the cases, the NT resolves and the babies are born healthy. So it is not a diagnostic test. Similarly, when we compare the fetal heart rates, it is mildly increased in trisomy 21 fetuses, mildly decreased in trisomy 18, while in trisomy 13 fetuses, it is substantially increased and it is above the 95th centile in almost 85% of the cases. Then coming to absent nasal bone. Absent nasal bone is a beautiful marker at 11 to 13 weeks. It is seen in around 1 to 3% of the euploid fetuses, while in trisomy 21, it's seen in around 60%, trisomy 18, 50%, trisomy 13, 40%. So assessment of the nasal bone improves the performance of combined screening, which increases the detection rate from 90 to 93% and decreasing the false positive rate from 3 to 2.5%. Then coming to the blood flow across the ductus venosus and the tricuspid valves of the fetal heart. We know that absent or reversed A wave in the ductus venosus is abnormal. So assessment of the DV improves performance, increasing the detection rate from 90 to 95% and decreasing the false positive rate from 3 to 2.5%. Reversed A wave at 11 to 13 weeks is seen in 3% of euploid fetuses, 65% of Down syndrome fetuses, and 55% of trisomy 18 and 13. It is also associated with cardiac defects and fetal death. However, we must remember that in about 80% of cases, they reverse A wave, the pregnancy outcome is normal. So it is also a not diagnostic test. Similarly, coming to tricuspid regurgitation, at 11 to 13 weeks, we can see a TR in around 1% euploid fetuses, 55% of trisomy 21 fetuses, and 30% of trisomy 18 and 31. The prevalence of major cardiac defects in euploid fetuses is about 4 in 1,000 fetuses. So when we see at the screening and detection rates, we can see alone maternal age, the detection rate is around 30%. Maternal age and fetal NT at 11 to 13 plus 6 weeks, it's around 70 to 80%. But if we combine maternal age, fetal NT, absent nasal bone, and the double markers, we get a detection rate of around 95%, which is quite good. And if we include the ductus venosus and tricuspid regurgitation, it also improves our detection rate. So apart from this, what else can we screen? Then comes the concept of the first trimester pentamarker test, which includes serum beta HCG, PAPA, inhibin A, placental growth factor, and alpha fetoprotein levels. The beta HCG, PAPA, and inhibin A helped us to detect aneuploidies. The alpha fetoprotein rules out neural defects, and placental growth factor helps us in predicting preeclampsia, with a detection rate of 98% and a false positive rate of 1.2%. Now, let us give some time to a test which has actually revolutionized the way of looking at screening the past 2-3 decades. That is the cell-free fetal DNA and or NIPT, which has reduced substantially the need for invasive testing. What is it? In some amount of fetal DNA escapes the placental circulation into the maternal blood. It undergoes apoptosis, and the fetal DNA lies outside in the circulating the maternal blood. So it is called cell-free DNA. It can be detected circulating in maternal blood from 10 weeks onwards and is rapidly cleared from the circulation post-delivery. Advantage is it does not affect this in subsequent pregnancies. So it is a simple procedure. Woman comes to us, we collect blood just like any other blood test, and we get the result. It is non-invasive. So there is no added risk of miscarriage. There is no upper limit for the gestational age starting from 10 weeks onwards. Highly sensitive. In fact, it's the most sensitive screening test. And so for all these purposes, it is very appealing to women. So when we compare traditional screening versus NIPT, we can see it is the most sensitive and specific screening with a detection rate of almost 99% in trisomy 21, 98% of trisomy 18-13, with a combined false positive rate of around 0.13% with a wider testing window. So it is the best screening test. It can be used as first line screening in conditions like maternal age more than 35 years. When we get certain soft markers in the ultrasound, history of a prior pregnancy with a trisomy, or with parental balance translocation with increased risk of trisomy 13 or 21. Or as a second line screening, when we have applied the previous screening test and we get an intermediate risk, we can ask her to do an NIPT. The result comes out negative, she is treated as a low risk woman. But if it comes out to be positive, then we go for an invasive or confirmatory test. So last slide about twins. As we all know, monozygotic twins, they share the same placenta. So the genetic information remains the same. So the risk calculated is pregnancy specific. Whereas in dicogenic twins, each fetus carries its own aneuploidy risk. So the risk is fetus specific. So if they screen by maternal NT, serum biochemistry, then the detection rate is around 85 to 90% with 10% false positive rate compared to 5% in singletons. But we should always counsel that no method of screening that includes a serum sample is as accurate in twins as it in singleton pregnancies. So to summarize, if you remember the first two slides, we had three concepts. We applied certain parameters to screen for these three concepts. And when combined, we got a detection rate of almost 90 to 95%. It is quite good. But we should also remember that the screening is not diagnostic. So any decision for termination of pregnancy should not be taken based on screening results only. But every pregnant woman should be offered a screening test whatsoever. Thank you for your patient hearing.
Very nice. You brought all the points and the markers which you have to look at and plan the screening. Do we have any questions from any audience? Can we stop this slide share, please? So, I mean, this is how we need to say, if you're thinking of the questions, let me just take you to a couple of slides, which I feel all of us should be aware of on how to go about screening. So first of all is this lovely program which we have called for ICOG Tarun Abhiyan. Congratulations to the ICOG and Sunita. Now, this is what Asit stressed on. We have to invert the pyramid of care. Now, just inverting the pyramid of care is not enough because we just don't have.
So your screen.
No, because someone else is sharing a screen.
No, I think, okay.
Yeah. Someone else started sharing this thing. So that's why this went off. So
can
first
you
of all,
reshare?
yeah, now you can get it.
Yes, please.
So first of all, we have to see that this pregnancy triangle is not the only thing. Yes, we've inverted it. So we're going to make all the diagnosis in the first trimester, 11 to 13, and least diagnosis at full term. And this is going to be done by the fetal medicine specialist, which could be OBGYN, radiologist, pediatrician, or whoever. And this is known as the first trimester triage. Now we have to worry about the pre-pregnancy evaluation today. The pre-pregnancy evaluation means the OBGYN or the maternal medicine specialist, you and me, have to do the non-communicable disease management before we let them go into pregnancy. And then after delivery, the thing doesn't end. So the post-pregnancy evaluation again you have to do for pregnancy-induced complications and management and prevention of NCDs. Now, this is the picture which you saw in one of the slides. So we have to watch this picture very carefully. Look at this picture. It's a fetus, umbilical cord in a sac, and there's a placenta. So we have to understand where do these markers come from. If we understand that and we know which chromosomal anomaly is causing problem where, we know that which marker. So the placenta gives you HCG, inhibin, PAPA, PLGF, SFLT. The liver gives you alpha fetoprotein and the open neural tube defects. The adrenals give you unconjugated estriol, and the nuchal translucency is a lymph collection between at the nape of the neck, because the lymphatics have not developed properly from the head to the thorax in trisomy 13, 18, 21. So now, whenever there are chromosomal anomalies, these are the markers which are going to get abnormal, high or low, which is been explained to you. So we must apply some strategies. Now, here are some 3 strategies which are available to us. The fully integrated strategy, a stepwise strategy, and a contingent strategy. For looking at our Asian population and Indian population, I think the contingent would be the best. But let's see what they are. So you have an integrated, see, I'm telling you this because in 1984-85, when we went to Singapore, Jaideep and me, for the fetal medicine training, every patient over 35 was subjected to an amnio, and only 3 or 4 were come positive. So we were doing 90 out of 100 amnio uselessly, subjecting them to a risk. So we needed to have this some strategy. So in the first trimester, they do an NT and a PAPA. There was no risk. And the second trimester, you did the examination all over again and then make the final risk. Not possible. 2 tests done twice, and the second trimester becomes too late. So then came the what we call as the stepwise strategy. So the risk was made in the first trimester as only high and low risk. All high risk, you do a CVS or NIPT, and a low risk, subject him to a second trimester quadruple marker all over again. Again, not a very good idea. So then we have the contingent strategy, which could be good for us. So the first trimester penta marker, as it was told to you, you estimate the risk, high, borderline, and low risk. Low risk, no further screening except for a 20-week anatomical ultrasound to rule out structural defects. High risk, CVS, not NIPT here. NIPT was put wrongly here. NIPT will be put in the borderline risk, CVS or amniocentesis. Borderline risk, you do the quadruple. No, not the quadruple now. We do the NIPT and then go. So this was what was there. So, and when we do these integrated, or what we call as the extended FTS, extended first trimester screen, you do the penta marker and you do the quadruple marker and the genetic marker in the second trimester. These are the 10. And you have an IPS, of course, for all, right from 10 weeks onwards to 20 weeks. Detection rate would be 97 with a false positive. Now, a test to be active should have a very less false positive rate, less than 3 or 4. And this was a good test to do, or a good screening. So how do we go about? First trimester, you put them, subject them to a quadruple marker or a double marker or a combined test. High risk, intermediate, low. Intermediate quadruple is again put wrongly here. NIPS now has come here, and CVS and a low risk only NI. In the second trimester, which is not a part of this, but we do a quadruple and an analmy marker, and the risk is 1 in 250. So Foxy made some charts. Now we had a chart made by Foxy long time back when Dr. Amit was there by Abbott on what you should do in pregnancy. And then we revised this chart in 2018, where we said some tests are mandatory and some for antenatal screening. Now antenatal screening means mothers to be screened also. And some tests are preferable. And then you have the genetic screening protocol. Sorry, that's not there. In a genetic screening protocol, the patient comes to you, whatever trimester you say that we have a test in the first or the second to tell you whether your baby is genetically normal or not. They have it is not a mandatory test. They have a full authority to refuse the test. So take a non-acceptance consent or a refusal consent. So you are safe. If they agree for the test, depending on the trimester, you subject them to a penta marker or a NIPS. In the second trimester, subject them to a quadruple or a NIPS. We know that NIPS as a screening test would be about 98%, and the quadruple marker would be about 80, 85 or 86, and the first trimester penta is around 90%. So NIPS based screening might be the only screening which will probably come to us in very soon as the prices come down, and as soon as we can look at more chromosomes rather than only the 5. So today with basic NIPS you look at 5 chromosomes. Then you look at only NIPT 21. That test is cheap available where because Downs is maximum. So screen only for Downs. Then you have the extended NIPS, which gives you about 22 microdeletions. Now, when the test comes positive, what to do then? No abortions, please, because it's screening. So then you have the invasive test. You have to take out the amniotic fluid or the chorion-villus sampling and subject. Then do what? With the amniotic fluid and chorion-villus sampling, do what? So you can do karyotype if you're looking for aneuploidies and structural rearrangements. You do a micro deletion, which is more common at 22, or you do a micro array where the NT is increased, but the karyotype is normal. And if you're looking for deletions and duplication. So that is, and we don't ask for NGS or a whole genome sequencing now at currently because that is not. We just ask for these. Otherwise, all the genetic, or you do a single gene defect if the probond has or the previous were a single gene defect or their sibling was a single gene defect or the mother parents are a single gene defect. So we can do a single gene defect and you match the probe to it, to that. So the take home message should be, as Asit said, screening should be offered to all population irrespective of the risk. A priori risk of age and history should be taken and a biochemical marker or NIPS and then the invasive testing. Now, patients have to understand that there are some benefits and there are going to be limitations of all the tests. Hence, the pre and post test counseling is very, very important. So those were my few of my take home message on how you should go about screening in the first trimester. We see a couple of questions and let me put them to you. What about, oh, by the way, today, 22nd of May is World Pre-Eclampsia Day. So we should be also talking about preeclampsia screening. So uterine artery Doppler in the first trimester along with SFLET or PIGF and the rest early preeclampsia can be predicted here and the late preeclampsia. And of course, all the you take the blood pressure correctly, you take the mean arterial pressure, all that has to be done in your pregnancy. That is very, very important. So a happy preeclampsia day, which is 15% of all our pregnant women, while chromosomal anomalies are 1 in 1,000. So preeclampsia screening in India should be stressed more, I feel, and I think. So now, Asid, there's a question for you. How NIPT can help a couple with balanced translocation? Or do they need an invasive procedure directly?
No, sir. Actually, NIPT is a primary screening you can use in couple with balanced translocation. Though they cannot identify the balanced translocation in the carriers, but they can actually identify the unbalanced translocation resulting in the fetus. So it can be used as a first line screen actually.
So we just showed you the extended, I showed you in my slide, there is an extended NIPT test available, which will look at 22 chromosomes and 22 microdeletions can be picked up for that. But please remember, it's a screening test. We have to say about screening test. What about PLGF? And I just, let's talk a little bit about PLGF. Yes, it?
Yes, sir.
The question.
PLGF.
What about PLGF?
Yes, sir. Yes, a PLGF, it is used as an extended first trimester screen to screen for preeclampsia. Yes, if we integrate it in EFTS or is a pentamarker screening, starting from 11 weeks onwards, when we do the NT scan and we use the uterine artery Dopplers and the mean arterial pressure, so it can be used as a predictor of preeclampsia. And
so I think routinely, because now it's becoming cheaper and available routinely in the first extended first trimester screen in the pentamarker, it is going to be included. And also, you said about alpha fetoprotein. Now, I always have a debate with the genetic people on alpha fetoprotein. I am advising alpha fetoprotein in the first trimester, but they said it's easier to look at omoteneural tube defects in the second trimester. And you do an alpha fetoprotein is a second trimester test and not a first. But we now have enough evidence, enough studies saying that you can use a alpha fetoprotein in the first trimester for screening also.
Can I say one thing?
Yes,
I
please.
don't know. I like to disagree with Asit's answer. Can NIPT diagnose balance translocation? When it is in a couple, they want to see whether it is in the fetus also. To me, NIPT cannot diagnose the balance translocation. Chinmay, fetal medicine consultant.
Yes, ma'am.
I think a chorionic villus sampling or a amniocentesis is the only one to diagnose the balance translocation. Yes, Chinmay?
So, ma'am, I think what he's trying to say, suppose there is a couple with balanced translocation, they are at risk of having a baby with either aneuploidy or unbalanced translocation. So, suppose this is like a case with a previous 2 or 3 cesarean section. If we do an NIPT first and diagnose that this fetus already has an unbalanced or the
Unbalanced,
trisomy or an aneuploidy, then you can take a decision for termination of the pregnancy at that stage only.
Correct.
So
Suppose
he
that
talked about
suppose there is a
unbalanced.
Okay.
yes, yes,
Okay.
sir. That's what he said. So that is for triaging. However, if the pregnancy is continued, you are very right, ma'am, that later
have to
on
do
we
an
will have
amnio.
to do an amniocentesis to look for
Okay.
breakpoint deletions.
Correct.
So the role of NIPT is only for screening the ones which are already aneuploid early.
So
Chinmay,
that's what
I
he
want to
said
pose a
broadly.
question. I want to pose a question to these younger people. In your practice, are you routinely doing an NIPT for every patient, or you're doing it only for the high risk, or you're waiting for the first trimester screen, that is the dual marker, plus the NT scan, and then you're deciding whether you need an NIPT or not?
Asit, you answer.
Ma'am, all patients above 35 years, or if she has a previous history of aneuploidy, history of unexplained fetal death, we are offering NIPT as a first line. Even doctors and those affordable patients, we are offering NIPT in the first place. Otherwise, rest of the patients, we are waiting for them for a double marker or extended first trimester. And if it is in an intermediate group, then we'll go for NIPT.
Even
What
This
do you
is
think
my
is
opinion.
what do you think is a disadvantage of doing NIPT first and not waiting for the first trimester scan plus the dual marker?
So in the
Uh,
future, it will be
Chitra,
only
otherwise
NIPT.
also I do NIPT by 10 plus 5 vagara. And by
Right.
12 weeks, we do the double
NTR.
markers and 12 plus 2, 12 plus 3. So that Pooja Loda puts it in a software and can give me a combined risk factor. But I agree with Asit, all VIP patient, irrespective, because they have more knowledge and they can afford, why not? And about 35, probably mandatory. But previous aneuploidy, depending upon what aneuploidy it is, like it is down, it is not going to be recurrent, trisomy 21 or so. So at a younger patient, previous aneuploidy because of anything else which is non-recurrent, I may not do it.
Right. So can I just tell you, we do it slightly differently. In any patient, of course, with a bad obstetric history, it's a completely different thing. There, you offer a whole lot of other tests. But in a routine normal patient who is above 35, we are doing the first trimester scan first plus the dual marker, waiting for the reports, and on the basis of the reports, deciding what should be the next test. So usually we may not do an NIPT for every patient who is above 35 unless they ask for it. With a bad obstetric history or with a those are different groups of patients, so we're not doing it for everybody. And that's what is the we have Ashwini Rathi over here, and so we have another Puja also over here. So that is the protocol we are following.
No,
But I
ma'am.
wanted to know from these younger
Screening, I think there is no one solution for everything because each person has a
correct,
different benchmark to start
absolutely,
with. So if there is a
absolutely,
lady who is 42-year-old and you offer her the standard trisomy, NT scan and
it
double
doesn't
marker,
help,
you
it
may
won't.
not bring risk down below 1 in 1,000 and she
Correct,
will still
correct.
need an NIPT. So
Yeah, yeah,
offering her
yeah,
as an NIPT as the first thing is fine.
yeah, but that is
So
above
we need
40,
a
so we
little
have
bit
that
of
cutoff for 40.
individualization.
So
Yes, ma'am.
Suchitra, what is going to happen very soon is with the NIPT blood, we probably might be able to do the complete karyotype of the fetus. Now that comes, which is going to be, I think, 6 months from now or so. Yeah, already there are some. Then all other tests will go. Then it will be only NIPT as screening. Then double marker, quadruple marker, pentamarker, except for preeclampsia screening, is likely to go, and it will be offered. NIPT will become cheaper, more accurate,
Even single
and
gene also it's coming, sir.
yes,
It's
single
going to
gene is
come.
also coming. So
That
it's
is so
coming. Within
fantastic,
six
but
months, within 6 months, we will have no other screening tests except NIPT. That's
and
what I
we
see.
will be doing TAPE only for screening of
Preeclampsia.
PH के लिए. That is very true. Very true. we
But
may
may I please tell all the younger people, of course you must apply all these tests, as and when required. Please don't forget the detailed history and apply the gestosis code.
Absolutely.
Cheap, easy to do. Agar 3N plus आया, just start off with EcoSprint and then of course go on to the detailed testing at the first trimester, because it's a preeclampsia day to day. Obviously, we have to talk about it.
So thank
Thank
you.
you
Thank
so
you,
much.
Asit. That fantastic presentation, lovely discussion. I think you
Thank you so
made the
much.
points very, very clear to everyone on how we should go about screening in the first time. It's going to be different. Everyone is going to have a different opinion, and depending on the patient profile, depending on the cost, depending on the history. But yes, it has to be offered to everyone. That is the main thing.
Thank you, sir. Thank you so much.
So thank you so much, Naren sir and Suchitra ma'am for the comments, and thank you, Asit, for a very nice presentation. So we now move on to our next young speaker, and that's Dr. Brinda Bacha from Jamnagar. So Brinda has a very challenging topic. Just like screening is one topic which always generates a lot of controversy and discussion. The other topic which does that is growth restriction and the diagnosis and the management. So Brinda thought it was too much to do everything in 10 minutes. So she has chosen to do how do we confirm the diagnosis of growth restriction. So Brinda, the screen is all yours.
Good evening, everyone. Is my screen being shared?
Yes, we can see your screen.
Yes.
It's all
So
fine.
can I start, madam? Yeah.
Yes, please.
Yes. Good evening, everyone. Today my topic is diagnosis of FGR, that is identifying FGR. Now, why is it important to identify FGR? Because 26 to 30% of pregnancy in India have small fetuses. 4 to 8 times higher risk of perinatal mortality, high risk of preeclampsia, significant short-term morbidity like intrapartum distress, hypoglycemia, hypothermia, and long-term morbidity in form of increased risk of type 2 diabetes mellitus, hypertension, and obesity, and increase in long-term neurological outcome. Now, for establishing the FGR, what we will do is establish the gestational age of the fetus, then we'll estimate the fetal weight, and then we calculate the weight percentiles. Now, methods for determining the gestational age is according to LMP. In IVF pregnancy, we do dating from date of embryo transfer in first trimester from CRL, and in second trimester from the biometry, that is BPD, HC, AC, and FL. Now, when we do the dating by first trimester, that is from 10 to 13 weeks plus 6 days on the basis of CRL, the discrepancy can be plus or minus 7 days. When we do it by second trimester, that is between the 14 to 28 weeks, we take BPD, HC, AC, and FL. Now, when the HC and FL, they both agree with each other, then we give dating basis on that. Otherwise, only on the basis of HC. Then the discrepancy can be plus or minus 15 days. And in the third trimester, that is more than 28 weeks, we take BPD, HC, ACFL, that is estimated fetal weight, and the discrepancy goes higher to plus or minus 21 days. If no scans are done till 28 weeks, then those pregnancies are called as inadequately dated. After 28 weeks, ideally 2 scans 2 weeks apart should be done to assign EDD. Once EDD is assigned, and it should not be changed in the subsequent scan. Now, in estimating fetal weight and percentiles, fetal weight can be estimated from various established published formula, but optimal weight is usually calculated using biometric measurements of head, abdomen, and femur, and we find the percentile and plot it on the growth charts. Now, before defining FGR, let us define what is SGA. Any fetus which is less than the 10th centile of its gestational age is defined as SGA. It is just a statistical deviation from the normal. Now, here we can see a bell-shaped curve of the birth weight where majority of the fetus fall in the between, while some are to the right and some are to the left. Now, this bell-shaped curve gets converted into the growth chart, where we have a 5th centile, a 50th centile, and a 95th centile. Now here the first dilemma that arises is which chart should be used. There are more than 83 published charts are available. Basically, there are two types of charts. One is the reference chart and another is the standard chart. Now the 10th centile varies in each of this chart. At 36 weeks, the abdominal circumference can range from 276 to 292 millimeters and can cause a difference at term of about 345 gram. Hence, standard chart like WHO, intergrowth or headlock should be used. Headlock 3 is universally accepted as a growth trajectory in the observational study across the globe. Now, in all the SGA fetus who are less than the 10th centile, 70% are going to be true SGA or constitutionally small. That means that they are going to have normal uteroplacental function with normal Dopplers and have no additional risk for perinatal morbidity and mortality as compared to AGA fetuses. Now the rest 30% are going to be true FGR. In those 30%, the 10% will have uteroplacental insufficiency and 10% are small because of either chromosomal, hormonal or structural problem or due to infections. Now FGR, how we define FGR is fetus less than 10 centile with Doppler changes or fetus less than 3rd centile with normal Doppler. But actually it is functional problem of unmet fetal need, inability to reach its genetic potential due to unfavorable environmental conditions. Since failure to attain growth potential is difficult to gauge, fetal size is used as a proxy with its all limitation. So it is not about the size, but size is used as a proxy of growth potential. Now, SGA or small for gestational age is physiological smallness, that is estimated fetal weight less than the 10th centile. While FGR is pathological smallness, where the estimated fetal weight is less than the 3rd centile or the weight is between the 3rd and the 10th centile with Doppler changes in umbilical uterine MCA or CPR. So now the questions are that are all SGA fetus FGR? No, because SGA can be in normal, that is constitutionally small fetus also. Now the second question is, are all FGR fetus SGA? Then the answer is absolutely no, because FGR occurs in two subsets of group. One is SGA and another is in AGA, that is average for gestational age group. In AGA fetus, those fetuses are between the 10th and the 50th centile. But whenever there is a dropping centile in the growth velocity or abnormal Dopplers, then even when the weight is between the 10th and the 50th centile, those babies need surveillance. Now here there is a graph where the perinatal mortality and the stillbirths increases exponentially when the weight falls below the 50th centile. Obviously, it increases more when the weight is below the 10th centile, but between the 10th and the 50th centile, also the babies need attention and surveillance. Now, the difference between SGR and SGA is, in SGA, the perinatal outcome is usually good, while in FGR, there is poor perinatal outcome and even the stillbirths. The cause is unknown and constitutional in SGA, while the cause being placental insufficiency in FGR. The Dopplers are going to be normal in SGA group, while Doppler signs of adaptation is seen in FGR. Delivery can be stretched till term in SGA, while in FGR the delivery should be done by 37 to 38 weeks. Now, early onset versus late onset FGR. Now, we will define it by the Delphi consensus. The early onset FGR is less than 32 weeks and having severe placental disease, while in late onset FGR, it is more than 32 weeks with mild placental disease. This 32 weeks cutoff is an arbitrary cutoff. When we see as a placenta, it has two compartments, maternal compartment, which we assess by uterine arteries, and fetal compartment, which we examine by the umbilical artery. In early onset FGR, the placental damage is going to be more than 30%. So for the definition, according to Delphi consensus, the solitary criteria is in early onset FGR less than 32 weeks in absence of congenital anomalies when the AC and the or the estimated fetal weight is less than third centile, or umbilical artery is having absent end diastolic flow. While the contributory criteria are AC or estimated fetal weight less than 10 centile with either or uterine artery PI more than 95th centile and umbilical artery PI more than 95th centile. In late onset FGR, the placental disease damage is going to be less, and it is having mild placental disease. The placental damage is less than 30%. So the definition goes like solitary criteria when AC or estimated fetal weight is less than third centile, while contributory criteria are any 2 out of 3, that is AC or estimated fetal weight less than 10 centile, AC or estimated fetal weight falling more than 2 quartiles on growth centiles, or CPR less than 5th centile, or umbilical artery more than 95th centile. Now the fall by 2 quartiles, falling by 1 quartile is equal to 25 centiles. So by 2 quartiles is equal to 50 centile. For example, supposingly a baby is growing at 80th centile and it falls to the 30th centile, then that fall is by the 50 centile, and those babies need surveillance. So in early onset FGR, the placental disease is going to be severe. So umbilical artery is going to be abnormal. As a result, the DV is going to be abnormal, but brainstem is immature and resistant to hypoxia. While in late onset FGR, the placental disease is going to be mild. So the umbilical artery is going to be normal. So DV is going to be normal, but brain is extremely sensitive to hypoxia. Early onset FGR, the problem is management, because it is easy to diagnose that a small baby with Doppler changes is going to be early FGR. But difficult part is management, because we are worried about the lung maturity and when to deliver. While in late onset FGR, the problem is being the diagnosis, because the late onset FGR can occur as late as 36 weeks or 37 weeks. So the problem is diagnosis, because here we are not worried about the delivery or the lung maturity. The fetal size is going to be small in early onset FGR, but it is not necessarily small in late onset. As we have already seen that late onset FGR, it can also be in the AGA babies. The placental disease is severe in early FGR, while it is in mild in late onset FGR. The umbilical artery is going to be abnormal in early, and it is going to be normal in late onset FGR. Preeclampsia is highly associated 50% in early, while it is 10% associated in late FGR. Now, hypoxia is going to be more severe in early FGR, but the tolerance to the hypoxia is good in early FGR. While the hypoxia is not that severe in late onset FGR, but the tolerance is poor. So we can compare early onset FGR to a Sherpa who is living on a high altitude and who is acclimatized to this low oxygen saturation, and so can carry on for a long time. While someone from a plateau, if is going to a mountain and cannot tolerate the low oxygen concentration and can suffer from mountain sickness, that can be compared to late FGR, where the hypoxia is not much, but the tolerance to the hypoxia is poor. So that is late FGR. Thank you.
You can stop sharing, Brinda. I think it was very nice. I would request Narendra sir or Suchitra ma'am to comment. Parag sir, I think you're only here, so you can comment on it.
I think Suchitra is there. Brinda very well presented, very clear messages and clear thoughts. I'm really happy that you've trained really well in your ICOG training, and of course you're doing some good work. So keep on doing good work.
Thank you,
That
sir.
example, that
You
example
can
was
comment
very
from
apt.
the fetal medicine perspective now.
Thank you,
I
sir.
think the example was beautiful what you gave regarding the person who is acclimatized to low oxygen and then responds in a different way, even if there is a fluctuation, and a person who is not acclimatized and suddenly has to deal with low oxygen. So that exactly shows why the early IUGR will still have a better outcome, because you've anticipated things, and even if it is a fetal demise, it is an anticipated demise. People don't feel very bad about it. And when it is something that you can correct, then you can correct. But late IUGR often presents as unanticipated fetal. So, what will be your one message to your obstetric colleagues in which will help you avoid the problems with late IUGR?
In late, usually early onset FGR can be diagnosed, as we have seen it, diagnosis is not a problem, while in late onset the diagnosis is problem. So ideally two growths and Doppler scan by a fetal medicine expert is a must, at one at 32 to 33 weeks, and the second is 36 to 37 weeks, because it late FGR can occur even at 36 or 37 weeks. Till then everything is going to be normal, and then suddenly if we don't do the scan and the patient comes with IUD, and so
So the concept of not looking at a baby after 32 weeks or after 28 weeks, if everything is okay, is not something which is useful. We should try and do at least one, the second growth scan at 36 and 37 weeks, because if there is late IUGR, then those are the babies who can be delivered between 37 and 38 weeks, like you showed in your thing. Whereas if the growth is appropriate, then you can leave these babies for long. Because in this zeal for doing normal deliveries and not doing inductions and not intervening, we will lose the babies who are late IUGR, because they will end up as unexplained stillbirths in the 38 to 40 weeks period. So that's very important. So we have with us Uday sir also. So sir, do you want to comment on Brinda's presentation? Okay, so thank you very much, Brinda. I don't see any questions in the chat box. If there are any questions that the audience wants to, and so you have got appreciation from Dr. Lakshmi Narayan Sahu from Bhubaneswar AMC, saying that both presentations are nice and highly informative. Congratulations to the young guns. So that's very well done. Good evening, Uday sir. You've heard this presentation on IUGR from Brinda. Do you want to comment on it?
Well, it's a good presentation, and we have to remember the importance of Dopplers. And in special situations like GDM, etc., in IUGR, the Dopplers will work and we can rely on them. But if it's a GDM and a large for gestational age baby, which doesn't fit into the IUGR definition anyway, but because of the large placenta, sometimes you can't rely on Dopplers at that particular in those particular cases. Otherwise, Dopplers are very useful to let us know when to interfere in the case of IUGR, and along with NSTs. But Dopplers are more specific, and it's important to take Dopplers in IUGR. It's important to do that.
Absolutely, sir. So there's one question in the chat box by Zoom user. I think it will be nice if you can name yourself so that we know whom we are communicating with. So the late IUGR diagnostic criteria, could you please repeat that? So Brinda, do you just want to repeat the criteria for late IUGR? So basically in late IUGR, there is a crossing of the centiles. About 2 quartiles one has to cross in terms of the growth velocity. And the estimated fetal weight less than 5th centile, or the abdominal circumference less than 3rd centile. And you have some very mild changes in terms of the Dopplers. Brinda, are you there? Do you want to answer this question? Okay, so the criteria for a late IUGR is quite straightforward, and that is the reason you have to look at the serial growth. So you should have seen the growth in the mid-trimester scan and compared that with the growth scan. So if there is a change in the growth centiles by more than 50 centiles, that is 2 quartiles, then suppose it was at 72nd centile and it has now come to 15th centile, then you can still diagnose it as late IUGR, although it is not SGA, because the growth is still above 10 centile. Dr. Sridevi Velanki has asked, which Doppler parameter decides need for delivery in late FGR? So, Dr. Sridevi, in late FGR, we don't use Doppler as a trigger for delivery, because in late FGR, the Doppler changes are extremely subtle. So, the umbilical and MCA both remain normal. There might be just a change in the cerebroplacental ratio, but that is only an indication to diagnose the late FGR. It is not an indication to deliver. The plan in late FGR is to take the pregnancy to 37, maximum 38 weeks, and then use NST to monitor. If there is an NST change, then you probably do a delivery. If not, then you induce the pregnancy by induce labor by 37 or max 38 weeks. Okay. Brinda, you want to add anything to these two questions?
Sorry,
Okay.
madam. Actually, there is a power cut and
No
disconnected.
problem. No problem. I think we've dealt with this. Thank you so much, Asit and Brinda. So it's like starting with A and B. So we will now move to the next session, which is a very interesting session. And before we go to there, Asit and Brinda, do you want to give us one line of your feedbacks? How did you feel speaking here and being, addressed directly by Dr. Naren Malhotra and Dr. Suchitra Pandit?
It was actually overwhelming.
Madam, it is a. Okay.
Yeah, ladies first. Let Brinda say first.
Yeah.
Okay. Madam, it is very overwhelming feeling because being a ICOG student and listening to lecture and now being as a speaker, so it is very overwhelming and very. And I would really like to thank you and Parag sir and everyone for giving us this opportunity.
Thank you, Brinda. Asit?
Yes, ma'am. Actually, it was overwhelming, and thank you, Parag sir, and you know what all happened, but still, it was actually very nice. And talking directly to Parag sir, Suchitra ma'am, Naren sir, it was nice. Thank you so much for giving this
Thank
opportunity.
you. Parag sir, you want to say something to them?
I'm really happy that we have come up with this program, because otherwise, we cannot showcase such talent, the young talent that we have in our country. I think this is
That
one
is developed in ICOG. Both of them are ICOG certification.
ICOG products, I should say. So, it also reiterates that the training that they are receiving and the exam that they face was worth the effort. So, Chinmay, I think as the course conductors, we should also pat our backs that we are producing some nice experts in the field of fetal medicine.
Sure, sir. Thank you so
Excellent
much. Thank
idea,
you, everyone.
Parag. The Tarun Abhiyan is a lovely name and an excellent idea to come up and bring up talent like this. Very good. Congratulations.
Thank you, sir. And we have it's really lucky that we have the past presidents of Foxy, past chairpersons of ICOG who've all come and sat through this. And that means a lot to all of us, sir, because, it's not easy for you to take out time. I know that, but all of you have done it and we are all so grateful, isn't it? So with that, we move on to the next session.
Another question, Chinmay, is what is
Yes, sir.
CTG, the computerized CTG? It's a new more detailed form of CTG, which actually, instead of visually looking at the variability, the computer calculates that whether the variability is okay and all, and gives you that result. So it is more important, and it will come up as a important parameter for CTG. This thing. Anything you want to add, Chinmay?
Yes, sir. The computerized CTG has ability to look at short-term variability. What we see in the regular CTG is accelerations and decelerations. So the computerized CTG is more objective and less, at risk of interpretation problems from observer to observer. In India, there are some centers who have put software in the regular CTG machines to create these, but they are mostly the institutes. I think AIMS had tried it once. Manipal had some experience like this, but yes, it is not regularly used. But having said that, the FIGO guideline is quite clear that for low resource settings, you have the regular CTG, which is equally useful. So it's not like if we don't have a CC, Barcelona protocol uses the short-term variability as one of the criteria, but it's not like if you don't have the CCTG, you cannot take care of fetal surveillance. Even the normal CTG surveillance will be useful.
Absolutely.
So,
The more CTGs you read, I think your acumen will definitely go up.
yes, sir. Yes. So it's so nice that the audience is interacting and asking questions, and the discussion is actually going in a productive manner. So we have some consensus now, but we don't like consensus all the time. So we're going to move into controversy, and controversy is always exciting. And I'm sure everybody will start waking up now big time, because we have a debate coming up, and this debate is on a very interesting topic. The topic is something like absent nasal bone. So if you have an absent nasal bone, is it okay if you've done an NIPT, or is it necessary that you have to do an invasive testing? So I request the audience to hold their thoughts, because everybody has one thought in their mind. And we have two youngsters again, Dr. Bhumika Shah and Dr. Kanan Kordawala. So they are again ICOG alumni, and Dr. Bhumika Shah is practicing in Rajkot now. She has also completed her ICOG certification course in fetal medicine in Ahmedabad, and currently she is working in Rajkot. And then we have Dr. Kanan Kordawala. She has completed her ICOG certification course in Hyderabad, and she is practicing in Ahmedabad. And both of them are really young and very, very academic in their approach to fetal medicine. So they will be presenting the debates. And to judge these debates, we again have two stalwarts. We have Professor Uday Thanawala, the past chairperson of the ICOG and past vice president of FOXY, and has held many, many eminent posts in different organizations. But again, sir is an extremely passionate academician and very, very encouraging of all the youngsters. So I think, sir, we are really happy that you are here, and you will be the right person to judge this, because he has a thorough balance of fetal medicine and obstetrics. So he deals with this from both ends. Seeing an absent nasal bone and then dealing with the patient queries. Our other judge is again Dr. Sadhana Gupta, another firebrand obstetrician who will have very strong views about, patients being guided or misguided in such conditions where there are minor markers. So absent nasal bone is something which always confuses people. And Sadhana ma'am has also held several posts in all organizations, has been the past vice president of FOXY, and is now a chairperson, vice chair elect for ICOG. So we'll be seeing more of her in ICOG in days to come. So, ma'am, I'm leaving the court for both yourself and Dr. Thanawala to take over.
So who is for and who is against amongst these two people? What is your line of the debate? Like if NIPT is normal and the nasal bone is not seen, how to proceed?
Right, sir. So suppose there is a patient who has come, and she has come with, like in the second trimester, she carries a report which says absent nasal bone, unossified nasal bone. The word we use nowadays for absent nasal bone is unossified nasal bone, because absent nasal bone often gives a little negative impact to the patient. They feel something is missing in the baby. So we say it's an unossified nasal bone. So unossified nasal bone is a marker for Down syndrome and many other things. So if she's already had an NIPT, do you still need to do an invasive testing? Or you would never ask for an NIPT, even if she's had an NIPT, you will insist on doing the invasive testing. So that's sometimes a dilemma for us, because they come with that report. And in the second trimester, an obstetrician is faced with that dilemma that NIPT is okay. So mostly all problems have been sorted out. Do I still need to do an invasive test? So
I think, Chinmay, this actually entails automatically that it is an isolated marker and it is not in conjunction with other sort.
So, ma'am, let's first listen to what these youngsters have to say, and then I'm sure we'll have a lot of controversy thereafter. And the purpose of putting this topic also is because first we can take the leverage with them and they have to battle it out. You have to present it in a way that you can professionally debate a colleague. So the ethics of debate have have to be maintained. The topic is definitely difficult and it has its own pros and cons. So your challenge is to present all the pros and cons. The challenge with the judges is to reach a final decision about what to do. So I think let the
But the
faculty
debate
get
is whether to do an amniocentesis or not to do an amniocentesis. That is what you're debating?
Yeah, the need for invasive testing. So Dr. Bhumika Shah is going to say, yes, there is a need for invasive testing. Dr. Kanan is going to say, no, there is no need for invasive testing. Let's see their points of view.
Okay, go ahead. Whoever is for
So-
the motion.
So Bhumika is for the motion. Bhumika?
Yes, ma'am.
Yeah.
Good evening, all the respected seniors and my dear colleagues. So, my topic for debate is invasive testing, whether it is advisable or not in case of an unossified nasal bone in a second trimester scan after NIPT has been given it as a low risk for screening. So, I'm going to speak in favor of invasive testing. So, during early human embryonic development, nasal bone develops in the membrane of dense mesenchyme overlying the cartilaginous nasal capsule. First, it becomes visible histologically by 9 to 10 weeks, and it has been demonstrated by ultrasound as a white line behind the fetal skin. The absence of nasal bone is currently considered to be one of the highly specific soft markers for chromosomal abnormalities, regardless of the gestational age. So we have also seen that nasal bone development varies among ethnic groups, and nasal bone absence or hypoplasia is caused by some internal or external factors in the embryonic development, which leads to interference of ossification process and delay of ossification. Prenatal nasal bone evaluation is a proven soft marker for Down syndrome, and the striking relation between nasal bone and Down syndrome was recognized in late 2001. Ever since, it has been consistently used as a part of screening for Down syndrome in the first trimester scan. Now, they also found that nasal bone increases linearly with the gestational age in euploid fetuses, whereas in Down syndrome babies, the nasal bone is remarkably uniform. So, hypoplastic nasal bone was linked as a marker for Downs. So, even the absence or a hypoplastic nasal bone during a 15 to 20 week scan also increases the risk of Down syndrome 83 times. Then we also found that absent nasal bone was related with other aneuploidies other than Downs, like trisomy 18, 57%, 13, 32%, and Turner syndrome 9%. So nasal bone hypoplasia was an established phenotype of trisomy 21. Then it was observed in association with trisomy 18 and 13. And of course, sex chromosome anomalies. Now it has been said that this may be a form of facial dysmorphism and may also be seen in other rarer genetic syndromes. So in recent years, unossified or hypoplastic nasal bone is said to be associated with some pathogenic copy number variants also. So we move on to the literature for the same. This paper, which was published in 2022, they evaluated over 5,000 females and performed invasive in around 1,500 invasives were performed. They found 28 cases of isolated nasal bone hypoplasia, of which 2 cases showed pathogenic CNVs. These were the 2 cases of pathogenic CNVs in the study. So the pathogenic CNV they observed was 7% in cases of isolated nasal bone hypoplasia. It should be noted that in the study, 29 of the cases which were isolated did not underwent any invasive test. So they had not been included and the sample size was small. Then in 2019, Liu et al., they also found that pathogenic CNV is in isolated hypoplastic nasal bone is associated in 5.1% of pathogenic copy number variants. They said that tertiary ultrasound evaluation and invasive diagnosis with chromosomal microarray analysis should be considered in fetal nasal bone hypoplasia, regardless whether routine screening for chromosomal aneuploidy or low risk is low risk or not. Zheng et al. In 2021, they performed the study in a Chinese population, and in their study also, they found the incidence of pathogenic CNV, which was around 7.4% in cases of isolated nasal bone hypoplasia. Now, this study, which is published in 2023, they evaluated 320 fetuses with nasal bone anomalies, that is absent or hypoplastic nasal bone. All the 320 patients, they underwent invasive testing and amniotic fluid was evaluated for chromosomal microarray. 132 cases were isolated nasal bone hypoplasia, in which we see if this second trimester isolated, there were 6 cases of pathogenic copy number variants. So the conclusion by the authors was that absent nasal bone was commonly associated with trisomy 21, followed by trisomy 18, and followed by sex chromosomal aneuploidies. The detection rate of chromosomal abnormalities is 5.3% in cases of fetal isolated nasal bone anomalies, even with low risk NIPS or maternal serum markers without other risk factors. So even with low risk routine aneuploidy screening result, second and or third trimester diagnosis of isolated nasal bone hypoplasia or absence increases the positive finding of fetal pathogenic CNVs or atypical chromosomal abnormalities. Possibility of the fetus carrying such pathogenic CNVs should be discussed with the parents, and prenatal diagnostic CNVs testing should be recommended to avoid missed diagnosis. So, recent evidence we have seen, they suggest that hypoplastic absent or absent nasal bone in second trimester is associated with pathogenic or likely pathogenic CNVs. Promising evidence of linkage of A and B as a marker for facial dysmorphism, even in isolated cases, is now found. And individual cases of syndromes like Friedreich or Wolff-Hitchcock are also being reported. So this needs to be evaluated. Now let us quickly look into the NIPT and invasive test. So NIPT, discovered in 1997, it is an excellent screening test only for trisomy 21. Now we already saw that screening test, it is applied to apparently normal population, means the population who does not have any risk factors previously. So detection rate of trisomy 21 was 99.2% by NIPT, while the detection rate of trisomy 18 and 13 were low, that is 96.3% and 91% respectively. And if we move on to sex chromosome abnormalities, the positive predictive value of NIPT is very low, that is only 44.2%. Therefore, when necessary, an invasive examination should be carried out to further establish abnormal screening. Results of NIPT are influenced by fetal fraction, gestational age, maternal BMI, vanishing twins, and confined placental mosaicism. So the chances of negative NIPT, though low, it cannot be overlooked even for trisomy 21. Karyotype, we have a detailed mapping of chromosomes, whereas microarray, they use chips on the sample, and it gives us a further detailed evaluation of the chromosomal material. So this tells us that as compared to chromosomal microarray and NIPT, we have seen that CMA identifies 52.4% of more information in cases of second trimester markers. So if we see invasive versus NIPT, NIPT is a screening test only. Karyotype for CMA is a confirmatory test. The chances of false negative NIPT cannot be overlooked. It is a known fact that positive predictive value of NIPT is low for aneuploidies other than trisomy 21. So the need to draw a clear line, knowing the limitations of NIPT, is essential to avoid missing of other aneuploidies, deletions, duplications detectable by CM or karyotype only. Also, if we see the timeline, initially when Down syndrome was known, like in late 2001, when it was associated with nasal bone, most of the samples we were evaluating the karyotype only. Later, when the technology advanced and more samples are being sent to microarray, we are finding more and more pathogenic CMEs in past decades. So evaluation by CMA should be offered with advanced genetics in case of second trimester unossified nasal bone. A gradual shift we have also seen in our routine practice for structural anomalies. There is a shift from karyotyping to CMA. So, and also when CMA is normal, many cases we also subject to whole exome or trio whole exome for better phenotypic genotypic correlations. So when we have such a lot of correlations, we should at least go for invasive. In conclusion, I would like to say that patients' point of view, they want to rule out as many as abnormalities as possible to ensure the healthy condition of fetus, taking into account social factors and reproductive costs. Our physician's point of view, we should be fully informed and consult patient according to their condition. Therefore, during prenatal genetic counseling, we should inform parents about the possibility of other aneuploidies and pathogenic CNVs if fetus has isolated NBA, and discuss with them the benefits and risks of further invasive chromosomal microarray testing. The final decision, though, remains the prerogative of patient. Invasive testing should be offered to all the patients, even if there is a low risk NIPT. Thank you.
Thank you, Bhumika. Excellent arguments, but I think you've overshot your time by 5 minutes, which is right, Chinmay? It was 15 minutes, right? What she
About
spoke?
13 I got, but yeah, she's overshot the time a bit.
So you have to be careful about keeping the time when you're in a debate. You just can't afford to overshoot your time, but you made good points, and we'll see how now Kanan will counteract that. Go ahead, Kanan. Unmute yourself.
Okay. Yes, sir. Can everyone see this screen, right?
Yeah,
Make
put
it
it
full screen.
yeah.
Okay. So, hello everyone. So, my topic, and to reiterate the topic, it is no need for invasive test in second trimester after normal NIPT for unossified nasal bone. So, ma'am already talked about the embryology part. Just the nasal bone assessment, the probe should be parallel to the direction of nose and side to side gentle tilt to ensure the nasal bone separate from nasal skin. Ecogenicity of nasal bone should be greater than the skin overlying. And 3 lines, the first 2 lines are horizontal and parallel to each other, resembling an equal sign. Top line represents the skin, and the bottom one, which is thicker and more ecogenic than the overlying skin, represents the nasal bone. A third line, almost in continuity with the skin, but at a higher level, represents the tip of nose. So nasal bone hypoplasia or unossified nasal bone is defined as the nasal bone length of less than 2.5 centile for the gestational age, and it varies with race and ethnicity. For trisomy 21, absence of nasal bone has 49% sensitivity with 1% false positive rate for and absent in 30 to 40% fetuses with trisomy 21 and 0.3 to 0.7% of euploid fetuses. And it is hypoplastic in about 50 to 60% of trisomy 21 and 6 to 7% of euploid fetus. Isolated absence of nasal bone has 6.5 times higher likelihood of having trisomy 21 in second trimester. The association with absent nasal bone with trisomy 18, it is 55%, 13, 35%, and in Turner's 10%. Other syndromes, ma'am already told, Wolff-Hirschhorn syndrome, Cry-Duchet, chromosome 13q deletion, 9p tetrasomy, 12q14, chromosome 7 trisomy, June syndrome, and craniofacial deafness hand syndrome. So unossified nasal bone was seen in 1 to 1.5% of total pregnancies scanned, of which 65.5% were isolated findings. 18.3 fetuses had 1 or more additional soft markers like CPC, EIF, ecogenic bowel, pilectasis, and 16.2 had associated anomalies, anatomic anomalies. So we have to see that 64.5% had isolated finding. In isolated unossified nasal bone, I reviewed 10 articles, and the conclusion emerged that isolated nasal bone with syndromic association was found in less than 10% cases, which is 7 to 8%. One other article said detection rate of clinically significant CMA findings in fetuses with non-isolated nasal bone absence or hypoplasia was significantly higher than that in the fetus with isolated nasal bone absence, which is 20% versus 6.6%. An isolated unossified nasal bone is nearly in 86% have a normal outcome. So as we have done NIPT here, so why did NIPT happen at first place? So NIPT has sensitivity of nearly ranges from 96.7% to 100% for trisomies 13, 18, and 21, and specificity is nearly 99%. Cost of the test ranges between now 5,000 to 10,000 INR. And recently, NIPT has been expanded to detect common microdeletions, duplication syndromes, or genome-wide copy number variations also. And here we are specifically discussing the need for invasive testing after normal NIPT in unossified nasal bone. If definitive diagnosis was the goal, how did NIPT happen? Here comes the aspect of pre-test counseling. The patient is already counseled about the association of unossified nasal bone and Down syndrome. And NIPT very efficiently detects Downs. So once that is reported a low risk, how can we justify to the patient the need for another test, and which is invasive test, which also comes with its own complications. ICOG guidelines also do not state a blank recommendation for invasive testing for hypoplastic nasal bone, even with a normal NIPT result. However, they emphasize that a detailed ultrasound should be performed in such cases, particularly when other soft markers are present. Invasive testing with microarray is recommended when absent or hypoplastic nasal bone is associated with other abnormalities. FMF guideline also do not mandate invasive testing in all cases of hypoplastic nasal bone with a normal NIPT results. So now with all the cards on the deck, there is need for at least 100 invasive procedures, specifically amniocentesis here, followed by CMA or whole exome sequencing to diagnose one case of pathogenic copy number variations after normal NIPT results. As for trisomies, NIPT has a high sensitivity and specificity. Invasive testing is not innocuous. It comes with its risk factors like miscarriage, 1.5 to 1% for amniocentesis, amniotic fluid leakage, vaginal spotting, infections like chorioamnionitis and septic shock can also lead to uterine contractions, preterm birth, and perinatal morbidity and mortality. Amniocentesis, we all know, same risk factors like RH sensitization is also there, and there can be injury to the baby, although very rare, a most feared complication, and severe cramping, fever, vaginal bleeding or fluid discharge, and infection at the insertion site or changes in fetal movement. Above all that, need expertise and advanced support. Costs are high, may not be covered by insurance. Approximately with the procedure and the reporting, it will cost more than 20,000. And it adds up to the confusion by picking a variant of unknown significance, which we call as WOOS, where phenotype is not fully understood. And without proper counseling of the couple, we sometimes end up losing these babies, which may be a normal outcome. So why NIPT was developed? To avoid the problems of invasive testing and to reduce patients' pain and suffering. And although quoted complication rate of invasive procedures are low, whoever suffers, it will be once in a lifetime for that lady. So take home key messages are: first and foremost, pre-test counseling for all genetic screening. Need for invasive testing has to be properly discussed beforehand. NIPT is advised in isolated unossified nasal bone. Low risk report need to be confirmed with an invasive. Need not to be confirmed with an invasive, sorry. And chromosomal abnormality rate in non-isolated is higher than isolated, and theoretical residual risk should be considered in genetic counseling. The references which I have taken, and so let the games begin again. Thank you.
Thank you, Kanan. I'm really very happy with this first series of Tarun that you took that human aspect, the clinical aspect, and the dilemma of technology, which is creating a lot of anxiety. So how much is too much and how less is too less is something that we have to learn the balance with the technology. And a beautiful presentation by both Kanan and the other other proponent. But I will say that in the Tarun, because it is Tarun thing, what is important that whatever we have a lot of paper, we have a lot of evidence, but actually the human science is not something like a code. So I will congratulate you that you have put that the basic, what are the clinical aspect and how the things and why NIPT was done. That question was also very, very important, because NIPT is just a screening test and we are not doing it routinely in Indian practice. So well taken by both the like a for and the against, but I think the Kanan has put fresh thoughts through it, and questioning like too much costly and too much invasive test, and also question about the thing that the pathogenic what is say the pathogenic variant, what we have, the CMV variant, maybe actually maybe just benign and they are not causing anything to it. So fetal medicine, what we have to think that always look the fetus and the baby with a love and with not a something putting all the faults, finding all the faults into it. I will invite Dr. Uday Thanawala for his comment on both the speakers.
So why can't I see Bhumika Shah anywhere? It's camera is
I
off.
don't know, my video is not working. I've been
Oh my
trying.
God. How sad. So anyway, I was quite impressed by Bhumika's arguments that, okay, you should not miss a disorder, even if it is very rare. And many of us in practice would probably want that, okay, even if it's rare, people go to great lengths to discover that. But at the same time, one has to be practical, like Dr. Sadhana said, one has to be practical and very pragmatic in counseling the patients. And I think Kanan has brought out that also, that if it is so rare, why do we need to do invasive testing if it is so rare? So I was myself a little confused, Chinmay. So what I did is I asked this to Chat GPT, and I'll tell you what the summary Chat GPT has given. So isolated nasal bone plus normal NIPT, low residual risk, but further evaluation with a detailed anomaly scan and possibly genetic counsel is reasonable. Invasive testing is not routinely indicated unless there are additional concerns. So that's I think what Kanan brought about. So ChatGPT is there for our rescue whenever we want it.
No, sir. I think,
But
yeah,
very
like,
well done. The debate was very well. I think Bhumika did a wonderful job of bringing out the points and presented her case also very well. And Kanan brought out what should be practical and pragmatic. So over to you, Parag and Chinmay, for your inputs.
No, Chinmay first, because
sir,
whenever we have
yes,
such doubts, we always call up Chinmay.
Call her up.
sir. So the topic was actually a bit unfair because it's a fact that isolated nasal bone, I mean hypoplastic nasal bone or unossified nasal bone is a marker for many things other than Down syndrome. So as a policy, we do not ask people to do NIPT for this condition. That is the standard thing. So the person who had to say that we will do an invasive had the easier job, and Bhumika presented all the evidence correctly and her references were spot on, because that's the rational way of doing things. Kanan, on the other hand, had the difficult job of, and that is the problem with scientific debates, because there is always one side which is a bit lopsided, and that was the lopsided way where we are saying we don't want it. So the topic we had done is, suppose she's already had an NIPT. So the patient often argues with us that we already did such an expensive test. Do you think I need to do one more test after that? So I think the rational way to do that is tell them that this does not prove all the genetic conditions, and the chances of finding those conditions are very less, but not negative. I mean, it's not zero. So if you want to go that extra mile, you can do. What we can do as clinicians is do another scan properly with an eye to detail for genetic syndromes. So all these syndromes which has been listed by both the speakers, they do have some scan findings. And if we do not find any of those things, then we again put the plate in front of the patient. But I think I like Kanan's slide about why was the NIPT done in the first place. And that is the question which all of us have to ask ourselves about pre-test counseling. When we offer a test to the patient, we have to tell them what is the extent of this test and what are the other options available. See, when we go through consent, one of the things about consent is what are the other alternatives to this surgery, including the option of not doing the surgery. So when you do a screening test, you have to give them what are the other alternatives of the screening test, including the option of not doing the screening test. So if that had been done well in advance, then we would not be in a dilemma in the second trimester. We put up this topic because it's a very common, cause of distress in the fetal medicine clinics. And what these two speakers went across was the distress which everyone has. So Kanan was having a very difficult time pulling out papers to refute what she has learned as a fetal medicine specialist, that she should be doing that invasive test. But there is evidence both ways. And like ChatGPT has also said, the final decision is with the patient. So we have to start the story at our end by doing good pre-test counseling, and the story will end at the patient's end by her decision as to what she chooses once we have given her the entire array of choices.
So, Chinmay, let me tell you one case which I had, and this patient was from Europe. And you know what? They do a NIPT there. They do not do a scan till 22, 23 weeks because there are no appointments available. So, there are cases where NIPT is done and no anomaly scan is done whatsoever.
But sir, that's not ideal. That's not
It's not
ideal. And
ideal.
they
It's
do
not
that
ideal,
because
but
they don't have.
there are many places where this may be happening. And
And I think it's time, sir. Now we have a better health system than than
100%.
America.
We are more
So
systematic, we are more up to date, and I was surprised. I said, how the hell haven't you got this done? How come they haven't done this particular scan? She was my niece who was abroad. No, they don't have time, so they've not done the scan at all. So that's the way it is. So
Actually, Uday, this is the thing, Chinmay, that Western world has out of resources, and we don't know actually medicine is now at the center of all economics and all sort of wars actually. So that is the thing that we Indians are applying is still common sense. It is a very good sign. And we are really worried. We just had what they do na chat box. So Abhi, this last week, we have a one examiner group, Dr. Shashaya, and then yesterday Times of India, a very brilliant article that how the young people are using that editorial and chatbot, and we are not having any freshness from the young. And today's were really encouraging that both the people, especially Kanan, put that freshness and the fresh thoughts to the system. So this is the way Parag ICOG to do, and it is very encouraging, very inspiring to see people like that, and our patients will be in safe hand despite all technologies putting missiles and drones on the patient and the fetus, and I hope we will have a very human world. So thank you, Chinmay. It was wonderful. And thanks for invite to be in first session. And Parag, to you, who is leader
In
to
fact,
carry
there
on.
we did have one case, IVF conceived twins, and one of the babies, nasal bone was unossified. So, then there was a debate what to do and what not to do. So Pooja and I, we tickled our brain, and finally we thought we will call up Chinmay and take her opinion. And then Chinmay suggested that we should do NIPT, and then if the NIPT is normal, then we can always counsel the patient and then let her take a call. And because she was absolutely not willing for an invasive testing. So
That's one
thankfully
situation, sir.
NIPT was, sir,
Yes, sir.
NIPT.
Because it's twins. If we decide to do amnio, we'll have to do amnio for both the babies.
Or the twins.
It's an IVF pregnancy. It's an isolated nasal bone. And you have the risk of miscarriage doubled because you are pricking it twice in a pregnancy which is already high risk. So when you discuss all these points with the patients, I think they will also accept the fact that let's do so it's not ideal, but it's not an ideal situation to be in.
I know. But then now, touch wood, she's around 26 weeks now. The baby's nose is still
Looks better.
so it is not better. Then otherwise,
one patient I will say Chinmay, एक बच्चा 3 साल का लेके आई तो she said मतलब 3-4 साल पहले, और मैं तो इतना जल्दी बच्चे में नुक्स नहीं देखती हूँ. So के मैडम यही बच्चा है, सब लोग परेशान कर दिए थे, इसकी नाक छोटी है आप ही की वजह से है ये. मतलब she is brilliant. So something about it, सबने परेशान करके रख दिया, नाक छोटी है. So this is something, and this Chinese and the Mongol race. So we also have a lot of variation, like our Northeast people, many people. So that racial variation also need to. We have a good paper from North India and South India that it is 15 percentile, like 50 centile is in Indian population. So sometimes, so Parag, I think Chinmay, we are very friendly fetal, like a person clinician, I think all of us. So this is the wonderful debate. And it is a very common scenario. It is not an uncommon scenario nowadays.
I think the take-home message, would you like to summarize, Bhumika and Kanan, in one line? What is your take-home message after listening to all points? Bhumika, we can't see you. That's really sad, but do something, no? Show us your face.
I've tried multiple times switching the net and all. I don't know why. Suddenly,
Yeah, at least you give your final take-home message, and I think we'll take a picture from you and separately.
So, of course, as I have to speak in favor of doing invasive testing, I would still like to put this in a way that though it is costly, though there is a lot of dilemma regarding doing it and all, but that 1001 patient who has a baby who is born with a syndrome, or who is born, the cost of carrying the baby lifelong, and postnatally having to look at that baby who is handicapped or mentally challenged or whatsoever the condition is quite high than doing invasive ones. So if
the choice has to be given to the patient to do
the
that.
patient has to be given choice that though NIPT at whatever amount of papers are there and whatever the evidence we have, NIPT still is confirmatory only and only for trisomy 21. We cannot rule
For
out.
trisomy 21 also, it's screening.
Yes,
It's
it's
not
still
confirmatory.
screening for 21 also, but for other remaining things, we cannot assure the patient that because the risk is 1% or 5% or whatsoever, that we have to put the things in front of the patient. We have
Okay.
to explain them that.
Sure. We got your point. Thank you. Kanan,
Thank you.
what is your take-home message? I mean, you don't have to stick to your topic because that is a little unfair, but what would you think is a sensible take-home message for everyone?
Sensible take-home message before NIPT, if I don't have to stick to the topic, the pre-test counseling should be proper. So if it comes, like, we have to counsel them, and if they are ready with the cost factor and with the very rare complication factor, they should go for invasive testing and they can skip the NIPT part. So ma'am, whatever ma'am said, whenever we need the 100% diagnosis, we should go for invasive. And so basically pre-test counseling should be proper and the dilemma should be skipped.
The entire gamut of fetal interventions and diagnosis depends on how you explain everything to the patient and what they know what they are taking. So there will be that one odd patient who says, I don't care what the baby has, I am not going to terminate this pregnancy. So that particular patient does not need this scary information also, because she has decided she wants to continue. There are women who are 42, 43 years of age having conceived after multiple IVF attempts, and they say it doesn't matter, I want to hold the baby whatever it is. And if that is that clarity the patient has, then we don't need to keep on scaring them with things that we find on the scan, because they are ready to accept it. So at the end of it, it has to be a patient-centered care, and we should just know what options we can give them. What to do, what not to do has to be a considered decision from the patient. So thank you very much for the debate.
Thank you.
And,
Thank you, Chinmay. Thank you, Parag. And thanks, Kanan and Bhumika. And
Thank you so
thank
much,
you, Dr.
Uday sir,
Sadhna.
Sadhna ma'am,
Yeah,
Parag sir,
Thank
and
you.
Chinmay
Thank
ma'am
you, ma'am.
especially.
Thank you
I
so
must
much.
compliment all four participants today. They've done exceedingly well, and Chinmay, special appreciation to you because mentoring youngsters is a bigger task. Making sure that the presentations go on well, and of course, all our senior people who are here as mentors and as judges. Thank you, Uday. Thank you, Sadhna.
Thank you.
And Suchitra for always being so supportive to all ICOG activities. So maybe we'll meet again on a similar platform sometime next month, where we'll have the episode 2 of the Tarun ICOG Tarun,
Abhiyan.
and we probably will have boys and girls who excelled in endoscopy will be presenting their videos. So thank you, and keep on attending ICOG programs.
Thank you, sir. Thank you so much. And I also want to thank the ICOG office, Neelima and Poonam, for sending out all the forms, following up on the responses. And really, Parag sir, this has been a very, very refreshing experience. So let's hope that it goes on.
So the next one on fetal medicine is 3 months down the line. So you can start preparing it.
That's
Thank you. Thank you all the viewers for being so patient. Thank you.